A very good morning to all. Today we'll be discussing about a very important module on small bowel perforations. So this question I have posted in my page that a patient was undergoing ERCP, endoscopic sphincterotomy for biliary pathology by medical gastro team. The procedure was uneventful, and after the procedure the patient had pain and tachycardia. CCT abdomen was done with contrast and showed retroperitoneal duodenal perforation secondary to periampullary injury. What's the type of perforation here? Okay, so the first thing is that we need to know what's the most common cause for small bowel perforations. So the most common cause, if you see, in olden times it used to be duodenal perforation, and it was due to peptic ulcer disease. But currently the most common cause is duodenal perforation, that's due to iatrogenic. So this iatrogenic happens mostly following the ERCP with endoscopic sphincterotomy. And if you see the incidence of this, the incidence of endoscopic sphincterotomy induced iatrogenic duodenal perforations is around 0.5%. So what are the other causes? Other causes for small bowel perforation. So the other causes for small bowel perforations will be most commonly the infections. So in India the infections are more common, like the tuberculosis and the typhoid can cause perforation, typhoid perforations, and it can be due to Crohn's disease. Crohn's disease can cause fistulization of small bowel and perforations and strictures. It can be lead to intestinal ischemia. It can be due to drugs, most commonly the NSAIDs, which are used in older populations, radiation induced injury, and it can be due to foreign body or malignancy. Malignancy in the sense adenocarcinoma or a small bowel lymphoma. So these are the most common causes, and we should not forget that very important cause is the diverticular bleed. Diverticular bleed in the form of Meckel's diverticulum, all this can cause profuse bleeding. So the second thing is, how will you diagnose this condition? The diagnosis, the investigation of choice is that most of these patients will be asymptomatic. Most commonly they are asymptomatic, but uh, but if these patients are having a progression of sepsis, fever and abdominal pain, then we have to suspect ERCP induced perforation. So the investigation of choice is always going to be a CCT whole abdomen, and we'll be able to find and grade the perforations, and that perforation grading system is given by what's known as the Stafford classification. So this is the classification system which is used for ERCP related perforations. So the classification system has 1, 2, 3 and 4 grades, and here if you see, the second one is the most common. And the first thing is that whenever these perforations happen, there will be free bowel wall perforations. Free bowel wall perforations. The second one is the most common, and that is retroperitoneal duodenal perforations. Retroperitoneal duodenal perforations secondary to periampullary injury. The third one is due to the perforation due to pancreatic or bile duct injury, and finally the fourth one is the retroperitoneal air alone. So most of the time these patients are managed non-operatively, that is by conservative management and supportive therapy, but this has to be differentiated from a very important condition, that is the ERCP induced pancreatitis. So because both these conditions will be having raised amylase, so it's one of the important differential diagnoses which you have to keep in mind. And the CT findings, if you see, there will be contrast extravasation, and there might be retroperitoneal air, paraduodenal collections are common. So retroperitoneal air is seen in 30% of the population. And like, how do you manage? The management in simple terms is that if at all there is a retroperitoneal perf which has happened, so these patients should be managed essentially non-operatively with supportive therapy. So if at all there is an intraperitoneal perf, so this has to be managed with a surgery when we do the pyloric exclusion with gastrojejunostomy. And in cases where there are jejunal or ileal perforations, so we manage the patient with what is known as the resection and anastomosis. So if we come to this question, so this patient has retroperitoneal duodenal perf secondary to periamplar injury, and this comes under type 2. Thank you.